particular strategies, opportunities, or roles we perform, and list 3 ways in which an interdisciplinary approach can improve outcomes in your setting. The objectives of the presentation are to observe World Physiotherapy Day, is where the original theme would have come from, WHO Healthy Aging, Myths and Exercise in Aging, Frailty and Fall Perspectives, Physical Therapy Role in Healthy Aging, Sarcopenia versus Frailty, Fall Prevention, Patient Case Examples, a Clinician Case Example, and Next Steps. So Physiotherapy PT Day is held annually September 8th. The theme for this year was Healthy Aging. It is a day to highlight physio's role in healthy aging and frailty, to improve public professional profile, advocacy for the profession and patients to governments, policymakers, and providers like yourself, and to recognize the impact physiotherapists have on global health. Next month is National Physical Therapy Month. Just a snapshot, we don't need to go into that in any depth, of just some of the services and skills that physiotherapists provide, as far as we are a licensed and regulated profession. We employ therapeutic interventions, we collaborate with our healthcare team members, and we act as care liaisons between providers and clients. WHO defines healthy aging as the process of developing and maintaining the functional ability that enables well-being in older age. Being disease impairment-free, thus, is not actually a requirement, because it's understood as we get older that we may have comorbidities that impact our quality of life. However, the question becomes whether or not it impacts our overall well-being and our perspectives on life and living. And it is dynamic as its complexity and its chronicity increases with age, with those same factors that I mentioned. The global context of aging: 1.4 billion age 60 plus by 2030, 2.1 billion by 2050, persons age 80 plus to triple by 2050, and falls in 3.7 million incidences annually. These are WHO statistics. The Decade of Healthy Aging, an initiative that was presented by the UN and WHO between 2021 and 2030. At the time of 2020, they would have established that about 14% of adults, of older adults, were unable to meet their basic self-care needs. Those may be simple needs such as dressing, being able to give and take their own medication, being able to deal and manage and comprehend and have cognitive proficiency with regards to money. What also was discovered is that there was a lack of adequate data on healthy aging, which lend credence to the fact that the elderly population may often feel invisible in relation to their particular needs or priorities. And 2/3 of those adults, those older adults, lived in middle and middle income countries. By 2030, the aim was, with this particular initiative, is to strengthen the respective countries' reporting habits, to have healthy life expectancy, to have research and evidence-based collaborations between countries and disciplines, and to borrow strategies and initiatives from already established areas, as with chronic non-communicable disease programs, and to realize that 1 in 6 people will be 60 at about that time. Now, this is a heavy slide, but I just wanted to put the information there because we also need to take into account elderly expectations with aging. Expectations, much like perspectives, are subjective, and they are influenced by an individual's perception, their implied access to care, or their personal motivation. PTs help to shape expectations, challenge stereotypes, and promote confidence, capacity building, and autonomy in life roles. Many older adults had expectations that prioritized independence, community participation, and role continuity. They had positive expectations for correlation that correlated with better physical health and activity engagement. Many older adults saw opportunity and growth despite society's view of them being negative with regards to the stigma that is attached with aging. Age stereotypes, both internal or intrinsic and external outside, influence an individual's physical activity, health-seeking behavior, and outcomes. Some components of physical fitness include health-related fitness, cardiorespiratory fitness, body composition, flexibility, muscular strength, and endurance, and power. And then there are skilled-related fitness, our ability to hold our balance when we hop on or off a curb, our agility, our ability to navigate obstacles, speed as far as how fast it may be for us to cross a street, whether it's a double or a four-lane road, power, our ability to be explosive, and coordination. With healthy aging, there is a prospective life course approach to mobility and movement. So when you look at aging, you look at having the most that you may have at childhood. Your foundation needs to be strong. Your movement patterns needs to develop. As young adults, you want to maintain the capacity that you built from childhood. In midlife, you want to prevent decline as you're now aging. And then as seniors, you want to protect function, as in your ability to get up and down from a toilet, in and out of bed, your ability to feed yourself, your ability again to dress and don and take off clothes. Some common conditions as it relates that may present themselves in persons 65 and older include hypertension. We may have seen these in our patient populations. While they may come in for one, they have, again, these comorbid conditions: high cholesterol, arthritis, obesity, diabetes, cancer, heart disease, depression, COPD, and asthma. And I would think in there may also be, we have had some patients with chronic kidney disease as well. Now, for the patients that are referred to us at rehab, most of our patients are musculoskeletal, whether it's fractures, surgical or non-surgical. Elbow, hand, and soft tissue fractures would be seen by our occupational therapist, hand therapist, Dr. Kana. Acute degenerative spinal pain, non-surgical, surgical, knee, hip, shoulder, arthritis. We do not quite communicate between clinicians as on the stage, because as you'll see later on, communication in relation to stage gives us all an idea of how we stage or prioritize management. Soft tissue injuries, ankle, knee, shoulder. We've also had a recent spike in total knee replacements and total hip replacements, both because of the joint program that we currently have at the orthopedic clinic and because we've had a number of patients gotten assistance from social services, as well as the Ministry of Health, to go places like Cayman. Our bigger cases for neurological would be strokes, CVAs, and spinal cord injury. We do have a cancer lymphedema treatment program that is spearheaded by our Deputy Director, Dr. Millicent Rollins, and also with our OTA, Christine Brown, and massage therapists. Post-surgical discharge, we see a lot of deconditioning and those metabolic diseases as well. Three common myths that you may encounter with elderly adults when it comes to exercise and aging. I'm too old to start. I mean, here in the Bahamas, it seems you're 55 and people think they're old. The fact older adults benefit greatly from exercise. Myth, weight harms the joints. In fact, strength protects the joints. It all depends on the type of weight and the type of activity. Myth, exercise equals falls. Fact, exercise prevents falls. Now, the physiotherapist's role in healthy aging includes, again, as I mentioned, in the application of a life course approach, frailty prevention, fall prevention, improving functional mobility, improving aerobic capacity, improving strength, flexibility, and balance. The methods by which we may employ management for these patients may include early intervention and fall frailty prevention, including where necessary, a home assessment. More often than not, that may be visual to see the surrounding spaces for things like whether it is throw rugs, lighting, navigation of furniture, and just general space, okay? Assessment and screening that may include a review of medications, vitals, and a cognition review on their ability to communicate where they are, their ability for short and long term. And then that leads to a mobility or movement plan of care program where the exercises are individualized to them. If pain has a factor in relation to their lack of mobility, we address those. We also always include patient education and self-management strategies because you're not going to be in physiotherapy for life. And we want to empower our patients. Biopsychosocial approach in understanding the role of the mind body as it relates to our perceptions on our conditions, our states, and our pain. And where necessary, ambulation, gait training, the use of or the reduction of ambulatory assistive devices. Return to work, recreational, functional training, fall recovery training for those patients where that might be a concern. We also, like I mentioned, with the collaboration, coordinate with other care providers, whether it may be a nutritionist, whether it may be counseling, and any other providers we may deem necessary, and refer to community programs. There are a few programs that might have group-based settings at churches, at gyms. I understood that there's something going on with urban renewal, I think once a month, that they have once a week, I should say, exercise program. And then once a month, I think they have like a gathering. When it comes to sarcopenia versus frailty, influence on fall risk, sarcopenia precedes frailty. Frailty, though, is not inevitable just because sarcopenia exists. Sarcopenia may be marked by a loss of muscle mass and function. Frailty is marked by a state of exhaustion, weakness, and slowness. Sarcopenia, disease, starvation, or disuse related. Frailty is age related. Muscle loss may be a hallmark. Weight loss may be the same for frailty. We may want to include an assessment that may be sensitive to sarcopenia in adults under 70. And we may want to include an assessment related to frailty in adults over 70. Fall prevention is a cost-effective initiative. Physiotherapies can assist in reducing injury by 33%. PT-based fall prevention saves $2,144 per episode. The cost as it relates to QALY gain, which is 13,420, more of an indicator of the disease burden as it relates to falls. And from an exercise program focused on improving the balance and compensation strategies for persons with fall risk, there was a 40% reduction in falls from a TAGO program. Now, when it comes to, as I mentioned already, the management strategies for physiotherapy, you may also include things like fall risk factors factors and getting an idea of how sensitive is this patient to fall risk. As I mentioned already, medication review, as far as certain medications may be linked to falls, and certain patients may have the opposite of hypertension and having orthostatic blood pressure issues that may need to be identified and appropriately managed. The CDC and that information was garnered from the CDC. As far as there's a physician's pocket guide also from the CDC that is easily accessible as far as preventing falls in older adults. It's a 2-page leaflet. Now, on this, it also has a very nice algorithm that physicians can go through to have an idea of the sensitivity of the patient in front of them to being at a high risk. Physical activity is preventative medicine. We've done a lot with disease management, and that has had a significant strain on our healthcare services. So now we know and have known for some time that we have to get to root cause, and we have to do a better job as it relates to prevention-based initiatives. Physical therapy and physiotherapy can assist in reducing the risk of cardiovascular disease, dementia, osteoporosis. It can improve mood, sleep balance, and cognition. And the WHO had recommendations of 150 to 30 minutes a week, in addition to resistive or strength-based exercise and balanced type exercises. Now, as I mentioned, with an assessment, physical activity, vital signs would also be something else we would want to employ the same way and with the same routine as we do with blood pressure, with heart rate, with respiratory rate, by simply just asking patients about their physical activity level, because we would know that regardless of your particular specialty or discipline, inactivity can be a precursor to a number of chronic disease states. And being able to, again, to identify those patients that you may need to consistently coach to engage in activities, monitor their engagement in activity would be very helpful. Another assessment that we may use is called a timed up and go test, where that helps to see the speed with which, as I mentioned, similarly about, let's say, if you have to cross the street, it assesses your function as far as you would get up and then you would walk a distance, turn around and get to sit back down. In a moment, I will show you that as far as that particular test. Let me see. Oh, and also we have with the Ministry of Health, piggybacking off of WHO guidelines, through the Department of Public Health, I would have found that we have our guidelines for adults 65 and older, again, with the amount of moderate exercise that they recommend, the number of days a week that they recommend, and with strength. What I don't see here on this one is balance-related activity. Okay. What I'm trying to do, excuse me for a minute, is let me stop sharing 1 minute because the Zoom is obstructing my ability to see the video. So this would be an example that I'm bringing up right now of the timed up and go.
Ability. To perform the test, you need a chair and a stopwatch, or a wristwatch with a second hand. Have your patient start by sitting on the chair, feet flat on the floor, one foot slightly in front of the other, and hands on the armrests of the chair. Put a line on the floor 10 feet or 3 meters away. Ask your patient to stand up from the chair and walk at her normal pace to the line on the floor when you say go. When she reaches the line, she should turn around, walk back to the chair, and sit down. Be sure to start timing on the signal go, and even if your patient has not started to move, and stop timing at the moment she sits back down in the chair. While she's walking, stand between the chair and the line in case the patient loses her balance and you need to assist. Observe and note the patient's posture, width of the base of support, step height, stride length, arm swing, and path. When the test is complete, record the time. Also record whether the patient used an assistive device, and if so, what type. A community-dwelling older adult who takes more than 12 seconds to complete the tug is at increased risk of falling.
Okay, give me 1 minute just to get back to my screen. So that would have been the timed up and go test. When I spoke earlier about the stages of arthritis, now this stepped care approach is from 2012, but the concept is similar to what we do as healthcare professionals, where based upon what we would see in the patient's symptoms in accordance with their x-rays, we may be able to stratify the patient into mild, moderate, or severe arthritis. And with those stratifications comes management. So when we have patients referred to us, we have patients that might be like, I just walked a flight of stairs and my knee kind of felt a little bit wonky. I've not had this issue before, and it's actually starting to resolve. That patient might be, and they have no use of ambulatory assistive device. Their gait is not significantly antalgic. That particular type of patient might be considered mild. Then you have a patient that their symptoms may seem to be nagging and taking a while to resolve. Those patients may be considered moderate. And as it relates to staging, those may be the patients that may be between a 2 and a 3 stage as it relates to arthritis. Let's say if I'm talking about knee arthritis. When you have a patient that you may have visible deformity, whether it is a valgus or a varus, and you may notice a loss in muscle bulk, and there is persistent pain, that patient may have anywhere between a 3 and a 4 stage of arthritis. And it's questionable about the long-term effects of physical therapy for that patient. Now, we know that the doctors don't treat x-rays, and it's in accordance with symptoms. So I'm speaking this part about the benefit of physiotherapy in relation to long-term and in relation to persistent pain that may not have been managed with the strategies that were used before. In a case example, let's say this particular patient I will label as non-compliant, and you see as we go, she had bilateral severe stage knee OA. She was an 84-year-old retired petite female teacher with a history of competitive walking about 5 to 7 years ago by her report. Her primary complaint was 10/10 pain and impacting her ability with walking. She would use a cane, and she wanted to return to gardening and getting back to this competitive walking and independence with her ADLs. She had secondary comorbids as far as coronary artery disease. She was obese, And she had somewhat of a decreased attention. I was trying to find the best way to phrase that. She was easily distracted in coming into the therapy facility and communicating and talking. And she had a very strong personality as the family matriarch. I think a number of us have encountered this type of patient. So, given our resource restrictions and from our assessment, we would have seen her once a week, but extended it out for about 4 months. We would have included evaluation, patient education, home exercise program modalities, therapeutic exercise, more in a non-weight bearing or partial weight bearing, understanding that given that she appeared to have severe OA, we didn't want to load her joints and have the exercise type be something that would hinder her progress. Therapeutic activity, neuromuscular education, manual therapy on occasion. The patient, however, was non-compliant. Outside of the therapy that was done once a week, there was nothing going on at home. By her own admittance, she would come in each session and communicate that nothing went on, and then go on to proceed to talk about her home life and talk about her grandkids and chat with the therapist and chat with the patients, okay? But her pain did actually reduce. She was independent in ambulation in the house. She admitted being able to walk in the grocery store, not for the entire time of shopping, but she was able to walk through the aisles holding on to the cart for support. She admitted being able to cook some family meals on Sundays with some modification. And this type of patient, after she had finished her course of therapy, we would have communicated and explained the nature of her condition, of her non-compliance, at which point at the time of discharge, she would have communicated that she's coming back with a new referral from her doctor, which she did. And we would have put her back in our referral system. On the other hand, we had a patient that was compliant with her exercises and with her management. She had lumbar spinal stenosis with radiculopathy to the right. She was a retired female banker with a history of daily walking, occasional tennis, and yoga and Pilates. Her pain complaints was 4/10, impacting her ability to stay active and to go to social events and engagements. She had no secondary comorbids. Her management was once a week, and the duration of her care actually lasted for 3 weeks. Again, the management included the evaluation straight through, but we would have included for her full weight bearing activities, whether it was treadmill or some balanced based activities in the hallway. We would have included some neuromuscular re-education strategies as far as implementing core control. And the outcome for her was pretty good. She was also a very compliant patient with the home exercise program given. She reported no pain. She was able to return to activity with advice and instruction on her condition, had a better mental health and mood. She was aware of her easing and aggravating factors. She was able to return to tennis, occasionally doubles versus single. And she was aware of the frequency, intensity, time, and type of activity that was provocative and easing for her. Now, I bring this section up as it relates to initiatives regarding quality of care. We would have heard of the triple aim that would have initially been improving population health, reducing healthcare costs, and enhancing patient care experiences. Over time, it would have been a quadruple aim, improving provider well-being, clinician well-being, and then more recently, there's a consideration in 2022 of including advancing health equity, where the access to care is fair and equitable. I bring that up because any different service within the institution, we are fully aware of resource restrictions, whether it is staffing, whether it is literally resources. So when we look at the public hospital, digitally, it says it's a 455 bed facility. Newspaper clippings may say 500 were admitted, 500 or more. That was in the Nassau Guardian with the date. There are ongoing renovations at any given time. There is persistent overcrowding. As I mentioned, resource challenges. We consistently have to be dynamic in our response to whether a ward is open or closed, whether a ward's located here, a ward's located there. There are increased wait times as to whether or not certain services are up and running or they may be down. And so that may also lead to evidence-based practice standards potentially being compromised. There's an increased staff attrition and turnover, whether it is a loss of professionals to other areas or countries, retirement. Persons may have just gotten out of healthcare entirely, and persons may be dissatisfied and resign. In our area, in acute care, as a snapshot, and I should say in rehabilitation service as a snapshot, we have currently 3 therapists servicing the entire hospital. We have outpatient services, adult, that is also in orthopedic and hand clinic, where we have 3 full-time staff and 1 PT. I am currently on leave. The outpatient pediatrics has 3 full-time. SRC out east has 1 therapist and 1 PTA. The staff employed between PMH and SRC also are responsible for covering weekend and holidays. The administration with the staffing has initiated recently the outpatient triage project for greater standardization, cross-training of staff, and the use of the healthcare professionals we have within the service. We have had the same issues as it relates to staff attrition and turnover, about 4 PTs in the last 4 years. And we are looking forward to some potential new hires on the horizon. With note, the referral sources can be from PMH, SRC, they can even be from the RAN, from the Department of Public Health, local and international private facilities, and Family Island. Now, when I said the clinician story, I bring this up because, as I mentioned about the quintuple aim and provider wellness, and we also would have gone over the life course approach. When you look at how you entered the system, and depending on how long you stay in the system, whether it is 2, 5, 10, 30, you're aging as well. And you're an individual who has things going on that impact the way you show up as well. So this particular person has civic issues and responsibilities. There are work, there are relationships, and there is health. So when you look at, say, work, you may have issues with just dealing with patients. You may have issues with how much money you make. You may have issues with benefits. You may have issues with the environment or the culture. You may have issues with staffing. You may be looking forward to when is your time to leave, right? Depending on where you are in the continuum. You have relationships. You may have a partner. You may have a child. You may have a mother or father who's still living. You may have a sibling. In relation to all of those, have their own interesting and unique dynamics that also play a role on you on a day-to-day. Then there's your own individual health, whether it is physical, mental, emotional, or social. You look and you can drop down and have issues, let's say mentally, with decision fatigue, stress and anxiety, where I gave an example of all the things that you're required to do and all the things that are available for you to do it. You look at social. Do you have the support? Do you trust to have the support? Are you engaged socially or are you alone? You're emotional. Are you self-aware? Are you, do you have interpersonal relationships? So that lends a case even more for interdisciplinary care and management, because if we work together, as opposed to at times it being that one person works in a silos and does their job, and then another person works in a silos and does their job, as opposed to looking at how what I do impacts you, how what you do impacts me. And we have a regular dynamic and expectation of being able to communicate between each other to get the end result. That could potentially improve our clinician experience within the institution. And I brought up the clinician example as well because there are also initiatives in larger hospital systems where you have employee health and occupational health that's actually integrated into providing care along the continuum for its employees in returning an injured worker back to work, in looking at the aspects of presenteeism or absenteeism and the underlying dynamics, integrating risk and employee health um, into the system to be able to have a more productive, engaged, and satisfied workforce. Now, communication requests, those are just some of the strategies which between ourselves from providers that are referring to us, what would be helpful to us to be able to appropriately and adequately assist the patients under our care from the time of the referral. As far as the interdisciplinary collaboration, partners in care of the patients we serve. Again, physios are autonomous, having mutual respect and value, focusing on patients because that's our client, assisting with discharge planning from admission, care coordination, and then back to the patient's person-centered care. There's also elements of what are called aging in place, where we know we have patients, and the Family Island patients come to mind, where they come to clinic on the day of an appointment and they are back on a plane to go back to the Family Island on the same day. Not whether it's canceled, not whether the doctor shows up or not, any of those things. They know that they ain't staying in Nassau too long. So those are initiatives as well in trying to not have patients in the hospital for long periods of time when we know that evidence speaks to them actually recovering better in their own environment, their own support system, their own network. Being effective, clear, and timely in our communication with patients and caregivers, shared decision-making, and trying our best to implement best practice standards. Future needs and considerations. Transformation in the healthcare system for affordable integrated care access, creating age-friendly spaces, whether that's having parks that are consistently manicured, that are set up to be accessed by persons with varying abilities, okay? Having sidewalks that are not impeded by a lamp pole, having sidewalks that are at the appropriate height that they should be. Again, the continuum of long-term care services. Let's say, for instance, I had a grandmother that passed away in 2020, and she had Alzheimer's dementia. And that was a struggle because our family, our immediate family is small. And she would have switched completely from the quiet lady to a belligerent cussing sailor and feisty. And we have a number of persons that are dealing with aging parents of, again, different morbidities that are also the providers, that we do not have systems, again, as in other countries that are there and available for persons that require long-term care. We can be more proactive in reframing aging stereotypes. One thing we all know is we're gonna die. So whether we die soon and not the time we thought we would, or we live a long, healthy life, we know that at some point in time we're gonna pass away. So our perspective now in our youth, we have to look that in the future, we're gonna be older. Like I said, I'm approaching 50, and like I mentioned as well with the life course approach, the foundation I would have laid down from my youth is now what I'm reaping in what I'm trying to maintain in this age. Programs to reduce ageism across sectors, again, aging in place, as I mentioned, in the workplace. More efforts of data collection, research, measurement of aging, looking to optimize the functional ability. You can have a patient that's functional and that's not pain-free. Pain-free, as I mentioned, with the patient that may have had the 10/10 pain, the bilateral knee OA. Pain-free may not be a reality for her because of the stage of her arthritis and her resistance to potentially having a joint replacement. Making better strategies to integrate physiotherapy across all care teams, again, at an point to reduce cost, and continuing to educate patients and families across the lifespan to mitigate risk. Conclusion: healthy aging is achievable, and PTs are essential partners in making it happen with dignity and alignment with their goals and ADLs. We engage older adults in co-creating care plans to foster adherence and satisfaction. From frailty prevention to aging in place, PT offers cost-effective evidence-based support across settings. But collaboration is key with physicians, consultants, policymakers to create systems that promote independence, reduce burden, and empower aging populations. So post-test, what is healthy aging? Who remembers healthy aging? Okay. Healthy aging refers to the process of developing and maintaining the functional ability that enables well-being in older age. How can physical therapy keep older adults independent, active, and well? It promotes mobility, balance, strength, reduce risk of falls, manages pain, delays or prevents fragility, supports independence in activities of daily living, offers patient education, and collaborate in interdisciplinary teams. List 3 ways in which an interdisciplinary approach can improve outcomes. Integrating physical therapy with primary care, nursing, other therapies, social work, and other health professionals. Interdisciplinary care improves early detection of frailty, can better tailor interventions, supports aging in place, and reduces hospital admission and institutionalization. Those are my references. And as a reminder, top 10 reasons why you would choose PT. It's holistic, comprehensive, evidence-informed clinical reason to problem solve, focus on function and mobility, diversity of tools, knowledge-based environments, we're a care liaison, reflective and consistent feedback, accountability, improves mental health and self-efficacy, individualized injury prevention and recovery, it across the lifespan, and bonus, there's a cost reduction in the overall healthcare costs. We do have the association, the Bahamas Association of Physiotherapists. If you want to know whether or not a care provider that is either soliciting or to which you refer is actually a licensed or regulated profession, no, because we do have a significant number of persons in the community that are telling unsuspecting public that they are physiotherapists, and we do have providers that are complicit in the referrals. And then later on, we have some a number of those same patients being referred to us later on in their care when our impacts may have been better served sooner. Those are my contacts as far as Instagram, Facebook, and email, and open for any questions. So this is my daughter, my mother, and myself. Thank you very much.
Oh, you know what?
Thank you. Thank you so much, Miss
No,
Newbold.
they roll it down.
We have some chat going on. Let's just solve that pretty quickly. Okay. Yes, thank you so much, Miss Newbold, for such a wonderful presentation filled with so much valuable information. I hope all of you have been listening, and I hope that you are ready to give your questions and comments to Ms. Newbold. And as you think about your questions, I just want to remind each of you that the feedback link has been posted in the chat. So please go and give your feedback for this presentation. Also, if any of you have joined using a name that is not registered with the Bahamas Medical Council, please register with the name that the Bahamas Medical Council recognizes for your license. Okay, so let's head over to the chat. Okay, so we have from Andrea Kalma. Good morning. Thank you for this timely presentation. You mentioned our Ministry of Health Healthy Aging Guidelines, but we were unable to follow along on the screen. Is it available online?
I will send you, I'm looking it up right now. I will put the link in the chat. Hold on one minute.
Okay, as you do that, we have Nurse Demerit saying, great presentation.
Here.
Okay, so the link has been provided for the guidelines for our Ministry of Health, Healthy Aging. Okay, do we have any more questions or comments for Ms. Newbold? I guess you were perfectly clear, Ms. Newbold. Information very well received.
Hopefully I was clear as day and not clear as mud.
We'll go with day, as clear as day. Also, just as a reminder to everyone, just being mindful that today is recognition of suicide prevention. So raising awareness regarding that. And we wear orange. There I am in my orange in recognition of suicide prevention. Also be mindful that our CMEs will continue as usual every second Wednesday and last Friday of the month at 8:00 a.m. So we hope to see each of you to our sessions moving forward. Dr. Burnett confirms that it was clear as day. There you go. So if there are no further questions or comments for Ms. Newbold, I would like to thank each of you for taking the time to fill your cup with valuable information to make you a better physician, a better nurse, a better healthcare provider. Thank you again, Ms. Newbold. We always look forward to your presentation. Until next time, have a great day.